we can move to the next item on our agenda, which is another informational item, COVID-19 health in Ann Arbor Public Schools update. Dr. Swift.
Thank you, President Johnson and trustees and members of our community. I appreciated that Trustee Lazarus very amiably teased Ms. Bacalor about being Ms. Fauci, and I actually have to share that she actually is my Ms. Fauci. So we receive regular updates on a daily and nightly basis from Ms. Bacalor. I'm sorry to say that some of the recently emerging data and research is not encouraging. And yet our job is to look at the facts and make decisions based on those facts. So Ms. Bacalor is here to help us to understand the latest developments and to also look at what metrics we will use when it's time to begin considering a possible beginning of the transition. Ms. Bacalor?
Thank you, and good evening, trustees. Dr. Swift, it's great to be back again. I am going to just give me about 3 seconds to get set up. All right, just checking to see if you can see those slides okay on your end. Looks good, okay. I have a really ghostly light on my face now because of my second screen I've got set up here. All right, well, I'm happy to be back talking with you about COVID-19 in schools. And tonight's presentation is in some ways a sequel to my July 22nd presentation. I will go into some more detail about our challenges and those considerations for moving to a hybrid learning model, and a little bit less on the research this time. For people who are watching tonight, if you are more interested in the health impacts of COVID-19, the epidemiology of the coronavirus, and how schools and classrooms are impacted differently than other industries, that presentation is available on the district YouTube channel or via the district website. So tonight we will get started by looking at some of that emerging research. The really interesting thing is since July 22nd, a lot has happened. First, we have had a surge in pediatric COVID-19 cases, almost 100,000 just in the last 2 weeks of July. And that's a 40% increase in the pediatric cases that we had thus far. We also are seeing a shift regionally and locally. 50% of new cases in the last couple of weeks were in people less than 30 years old in Washtenaw County. We know a lot of them were in that 20 to 30 age group, but still this is a pretty big shift locally. And as Dr. Swift mentioned, we have seen multiple outbreaks in our region due to some of the team parties that have gone on. And that has happened in other areas of the country too. So just to summarize what we know and don't know about children in COVID-19 at this time, we know that still that children generally are experiencing the illness in a milder way than adults, and some are asymptomatic. There is new data, new analysis out on MISC, the multisystem inflammatory syndrome in children. And this new one looked at a total of 570 patients. So this is an increase from my last presentation. And these were cases that were reported from 40 states, DC, and New York City separately. 2/3 of that 570 caseload were admitted to the ICU, and unfortunately and very sadly, there were 10 deaths. What continues to be very troubling about MISC is that there is still this disproportionate impact on Latino, Hispanic, and Black children. So of that 570 that was part of this analysis, there were 40% were Hispanic or Latino, and 33% were Black, and 13% were non-Hispanic white. So when we're seeing the illness, when doctors are seeing it in their emergency rooms, what they're seeing is an average of 4 organ system failures and going on in the one patient. And about 2/3 of the kids do not have any pre-existing underlying medical condition. And, you know, they're coming in and they're becoming very sick. So we just need to think about it. It's still very, very rare, of course, but we still need to have that in our minds as something that's going on in the world, in the US. And while we know that children do transmit to others, we really need more evidence. And last time I talked about that giant 60,000 person South Korean study that looked at age breakdowns and found a strong suggestion that 0 to 10-year-olds are less likely to transmit it than 10 and up kids. So we're just continuing to monitor if there are age differences in transmission. One of the things I really wanted to focus on tonight is children as asymptomatic carriers. And last time, you may recall, I introduced you to a fun term called virus shedding. And what we're looking at and finding is that children appear to be silent shedders of coronavirus, just like adults. So for adults, we have pretty good evidence that 1/3 to 40% of infected adults never develop symptoms. Asymptomatic adults carry as much of the virus right up there in their nose and throat and lungs as symptomatic adults. So now it appears that children are also likely to be asymptomatic transmission. So there have been a couple big outbreaks that people have talked about, and one of them is the Georgia overnight camp outbreak that happened just a couple weeks ago. This was 260 cases in a pretty astonishingly short period of time. The students and counselors were only together for a few days and nights, and it resulted in 260 cases. So of the 136 cases with available symptom data, 36 patients reported no symptoms at all. I've also been intrigued by a study conducted in France of children who were being admitted to the hospital for any reason. The French researchers were testing their pre-screening questionnaire to see if it would catch all the cases of COVID-19. And the pre-screening questionnaire, probably all of us have filled one out by now. It's if you're going to a public place or you have an appointment and they ask you to just quickly do a symptom check and you run down the list of symptoms. So this study was looking at if the pre-screening questionnaire worked to catch actual cases as they were coming in for whatever reason to the hospital. So they did the pre-screening questionnaire, and then they also did a PCR diagnostic test of all the patients as well. And what they found was that 10 of the 22 positive pediatric patients were asymptomatic. So the pre-screening questionnaire did not catch them. So of course, this is a small study, but I did notice that the study size overall was 438, which is roughly one of our elementary schools. So again, we need to be aware of this, and I'm following the research, I would say almost fanatically. So why is asymptomatic infection in children important to school districts? So you've heard me talk a couple times before about our layered approach. We are layering all these different strategies and protocols so that if some of them fail, others of them will still work to protect the staff person or the student. The problem with asymptomatic infection is that a whole bunch of our layers fail in that situation. So for example, we're going to have a pre-screening questionnaire. Well, that's not going to work. We're going to have protocols around staying home with sick, like we always do, of course. That won't work if the student is asymptomatic. We're going to have a protocol that helps children who become symptomatic at school. Of course, that won't work either. The last one is a little bit different. We know that there will be times, if there's a case in a classroom, that we might have to close or dismiss that classroom full of kids for 14 days. So if we have asymptomatic kids in the mix, and maybe in the classroom next door, for example, or somewhere else in the school, we're not able to get a full picture of who has the virus and respond fully to the situation with asymptomatic kids. So if the left side there is not really in play, we are even more dependent on the items on the right. It's the personal level prevention. It really becomes critical for us as layers. And those are the physical distancing, it's face covering, and hand washing and sanitizing. This is basically all we've got, and we're counting on those to work. So let's move on to ongoing challenges for school districts. And you might be saying to yourself, Jenna, or saying to me in your mind, you just talked about a big challenge, and that is true. I did. So that challenge will be threaded through some of the other ones that we'll talk about now. So let's talk about two other challenges: testing availability and classroom air quality. I just picked this one succinct quote from one medical professional. He said it last week, but there is broad scientific consensus that what we truly need to reopen schools to in-person learning is a robust, reliable process for testing, contact tracing, and isolation and quarantine. I'll just add that in. Again, this is another critical layer of protection for our community level transmission in school communities. The next slide speaks to a big picture, and it's a little complicated, but I'm going to walk you through it. All right. Oh, doesn't this look fun? All the nerdy people are like, yes, two kinds of graphical data representation. All right. So back in April, the Harvard Global Health Initiative released a roadmap for pandemic resistance. And that the roadmap really spelled out how do we suppress the virus in the US using massive scale testing, tracing, and an isolation plan. So specifically, this roadmap said that we need to build up, the US needs to build up to a diagnostic testing capacity of 20 million per day to stop the spread, and launch a huge hiring and training program to bring on board at least 100,000 contact tracers nationwide, and provide supported isolation and quarantine. And lots of people called for this massive testing strategy. And of course, this didn't happen. So this plan was meant to prevent illness, save lives, and prevent a cycle of opening and closing the economy. So what we have today instead is a patchwork of mitigation testing. So the difference is that with suppression testing, you're doing surveillance testing of healthy people to find those who are asymptomatic and quickly move to isolate them. With a mitigation testing strategy, the goal is just to try to reduce transmission. And alert viewers who remember my presentation from last week, or July 22nd, may remember I talked about the R number, the reproductive number. And so with a mitigation strategy, you're trying to go from the reproductive number in the case of the coronavirus, which is between 2 and 3, you're trying to get it between 0 and 1. So for every one person who has the coronavirus, they're only spreading it maybe to nobody or maybe to one person instead of 2 to 3 people. All right, so we have our mitigation strategy, and that is all just building up to me explaining this chart to you. This chart is pulled directly from the Harvard Global Health Institute's big database full of information about testing. And the blue line represents the United States and its 7-day average of testing. The red line represents Michigan. So hooray for us, and thank you to Governor Whitmer and Dr. Khaldun, the Chief Medical Director, because they have really focused on getting much more testing in Michigan. We're beating the rest of the country, and that's wonderful. And you can see in the tiny little box there, the little rectangle, our number of daily tests per 100,000, the mitigation target, which is 157, guess I could use my cursor and do some circling. That might be fun. Okay, there we go, 157. And then our suppression target would be 560 per day. And obviously we're not there. So we just have to kind of face facts. We're mitigating, not suppressing the virus in Michigan, but at least we're doing better than some other states. And just one more thing to say about it. I'm really trying to hold back. I could go on all night about it, but the suppression level is really around rapid testing, use the saliva testing versus the up the nose testing. And I know that at U of M, they're going to be doing surveillance testing of students who live in the dorms. So all of this is leading up to, I have to get my cursor back, my next information about what's happening locally. So, you know, as Dr. Swift mentioned, we have a contact tracing process and protocol. How is it all working? What is our status right now? So as I mentioned with the testing, we have higher level of diagnostic testing than many other states. Our big issue continues to be turnaround time for results. It can range from the next day to 5 days to even 10 or 12 days. And that renders it sort of moot in some cases. Ideally, we would have at least biweekly surveillance testing of all students and staff for a school district to operate in a suppression mode, but we don't. So there's an effect from the testing to contact tracing. The efficacy is directly impacted based on the testing turnaround times. We do collaborate with the local health department on tracing. And then moving down to the next part of it, if the test comes back too late and we're not able to get to contacts in time, the isolation and quarantine can also be impacted. And again, we are cooperating with the local health department on isolation and quarantine as well. So we actually have some cases that I can talk to you about. We had four COVID-19 cases within people who are connected to the school district and on campuses this summer. So we were able to try out our protocols and see how people were feeling and how it all worked out. So what happened? So 3 of the 4 cases actually were in individuals who live in the bigger Detroit region, which is 9 different counties, not in Washtenaw County. And it was a good reminder to me that the AAPS community goes beyond Washtenaw County. We have lots of staff who drive in from, different places. We have a, small number of students who do as well. And then we also have lots of parents who are driving out of Washtenaw County for various reasons every day. So just thinking of us more regionally, I think is helpful. So we instituted some internal notification protocols, and I'm happy to say that they worked, and I'm working on making them better. There were some cases where contact tracing was delayed by test result turnaround times. And what was interesting about that too was one person just completely misremembered like everything about what had happened. And I was able to figure that out because in talking with the health department, the test results didn't line up to the dates the person had given me, and then go back and talk about, oh, it was actually all of that happened a week later. So that delay can also be hard just to remember stuff, and I can't remember anything. So I can appreciate how this becomes harder over time. I do want to say people were very willing to cooperate, and I wouldn't even call it cooperation. It was just like a partnership on trying to figure out who was I in contact with right before I was sick and when I was sick. And a lot of people really trying to figure out, how the heck did I get this? They've been following all the protocols, and somehow they got it. And it's just a reminder that anyone can get it. It's just part of our lives now. And I'm just really happy that people called right away. And the part that is the best is that all 4 people recovered and no further spread occurred at least in the AAPS community from those 4 cases. All right, let's shift gears a little bit and talk about classroom air quality. So, you know, as everybody knows, I think by now, right, the indoor environments that are most concerning for transmission, much more than outdoor environments. And especially when you're in kind of closed indoor environments where there isn't a ton of air circulation. And this, again, kind of this thread to the presentation, the complexities of asymptomatic individuals become even more apparent because their bioaerosols are produced just during regular breathing and speaking, and that is looking like it's a part of the spread of the disease. We also know that there are special challenges with classrooms. It's around the density and the time spent in the classroom space, and I will just teach you guys the term I heard recently about our need to de-densify. So excited to share that one. We need to de-densify our classrooms. And of course, that is the plan for when we are able to sort of start migrating back into schools. But there are just these special considerations for classrooms and indoor environment. And what we know is that there is this ideal for all the different ventilation and filtering and all the stuff you can do. And it's really possible in a hospital setting or a healthcare setting and less likely to be possible in a classroom space. We can do all that we can to increase that amount of outdoor air coming in. We're never going to match a hospital for that, and we just have to be realistic about it. So how do we make classroom air safer? The number one thing that we can do that's within our power, besides like opening the windows and getting indoor air and doing the ventilation system things that are feasible for us to do, is source control. And that means masks. We know masks are effective. They provide that critical barrier. They provide air filtration at a personal level. And we know it's an essential way to reduce the risk of infection. And this is a great graphic showing it. For some reason, I don't know, to me it looks a little bloody. I'm not sure what that is, but it's just illustrating particle size and amount that's coming out and how there's maximum exposure from the top infected person on the left to the non-masked person on the right, and then minimum exposure if both people are masks. So it is of my opinion that we need to look at universal face masking in schools. And the CDC agrees. If we are looking and trying to achieve the lowest possible chance of transmission, we need to look at universal masking and with that 6-foot barrier. So, and it's safe for people 2 years of age and up to wear them, and it's especially necessary if that social distance cannot be maintained, which is really the case in our classrooms a lot of the time, if we're having classrooms the way we'd like to. So let's talk a little bit about K-12 students and masks. So we know that they're great for source control. We also are just finding out that they also may serve as PPE, or personal protective equipment. So the CDC recommends teaching students how to use cloth face coverings before returning to school, practicing at home, and during the school day having a mask break, like for meals, if kids are going to be outside running, being very physically active and they're far apart, taking a mask break then. And of course we know that they're not going to be feasible for everybody. They should never be on someone younger than 2. Anybody who has trouble breathing, is asthmatic. Of course, we wouldn't put a mask on someone who's unconscious. And anyone who's really not going to be capable of removing the mask during an emergency. And these are coming right from the CDC. There might be other conditions that make it very challenging to wear a mask that we'd have to find some accommodation for, but those are the main ones that we know. All right, now we've talked about challenges, we've talked about solutions. So now let's move to considerations for beginning a transition to hybrid in-person learning. I know a lot of people have been asking, how will know it's time to start looking hard at moving some students back into a face-to-face setting? So let's take a look at what some of the metrics are. Once again, I'm giving you a little intro, and there's a complicated slide coming up, but don't worry, I will walk you right through it. All right, so we're really because we're in Michigan, we're part of the My Safe Start plan and the My Safe Start map. And of course, when we look at metrics, and I took these words right from the plan, the metrics have to be complemented with an understanding of the on-the-ground contextual realities. And isn't that a great term? And really, it's what's happening right in our neighborhoods and right in our town. The central question we need to ask is, what's happening with the epidemic in our region? Is it growing? Is it flattening? Is it declining? And there are 3 different metrics that we look at for that. And again, this is right from the plan, but I'm going to show you a little bit more too. The 3 things are the number of new cases per million, and by making them per million, we are able to compare ourselves against other jurisdictions, other communities, other states, other countries. And we want that, of course, to be low, right? We want to have low new cases. We also want to look at the trends and just straight up new daily cases, which are going to vary quite a bit from place to place depending on your population size. So those 2 go together. And then the third one is the percent of positive tests. And this is, you take your number of positive tests over all of the tests that are done, and you have your percent positive. And this is interesting because it shows you if the testing levels are high, and there's low positivity, that's great. And that's kind of how we're looking very locally right now. But if there's high positive tests, there are also high proportion of positive tests and not very many tests going on. It could suggest further disease spread. We also must pay close attention to trends for each metric. Is it going up? Is it going down? So those are the 3 I really want to focus on for tonight. But I do want to mention, I put over in this little blue square type thing, additional metrics include things like hospital capacity, PPE availability, testing and contact tracing. I can't stop talking about testing. Isn't it funny? Okay, so let's take a look at the My Safe Start map. And I just encourage everyone to go visit this website. So we're looking at the Detroit regional cases per million over time. So remember from the previous slide, that was one of our 3 metrics. And get my cursor out again. So we see, like last time when I presented, we had this big peak, and then we had this lovely long decline, this lovely dip. And then unfortunately in July, we started coming back up, and now we're kind of flattening. And look, we might be coming back down. This is still over 40 cases per million. We still need it to come lower, but if we all keep working together, we need to bring it down even more for a longer period of time. And I'm just showing you that in the Detroit area, which is these 9 counties, we are still in this bright orange, medium, high risk, along with the rest of the state right now. There might be some areas that are not quite as bad. I can't remember from the state map. All right, so this is where it gets really interesting, at least to me. Let's take a look at the countries that reopened their schools, the date they reopened, and what it looked like for them when they reopened in terms of daily cases per million, and the positivity rate. So remember last time I said we can't look at apples to apples? Well, I found a way that we can look at apples to apples, and it's pretty exciting. So you can see at the top here, we have our US daily cases over almost 66,000. Cases per million are at almost 200. Positivity rate is 8.3. Now let's take a look at some of the other countries that we know have already reopened their schools. and take a look at their daily cases. Of course, these are much smaller countries. So, you know, we can look at daily cases, but we can also think, well, it's a much smaller country. So then we can look really comparing daily cases per million population. And that's where things get kind of bonkers with where the US is and where all the other countries were when they reopened schools. So then you can look at the positivity rate and see, oh yeah, once again, except for Japan, we have a pretty significantly higher positivity rate across the whole country. However, when Japan was at 8.7, they were at 3.5 cases per million. So a little bit different picture there. I know you're saying to yourself, who cares about the US? What about us? And so I pulled the data from the My Start map. This is available to anyone. Feel free to take a look. And as of, I pulled this yesterday, and it was the 7-day average ending August 9th. So we can see the Detroit region, daily cases 250.9, daily cases per million 47.9, positivity rate 4.1, and this has actually gone down a little bit, so that's good. However, the daily cases per million have gone up. In Washtenaw County, the picture is better. We have lower daily cases per million. Still, though, this is higher than most of the other countries, and our positivity rate is very low in Washtenaw County. I do want to point out that some of these countries, I don't want to say a lot, some of them have had pretty significant outbreaks since they reopened. Israel is one that has had kind of rotating outbreaks, and Japan has, South Korea's had small ones. So it's not like other countries were just perfect. They just opened and everything was great and everybody had a pony. It has been a struggle in some areas. But what is really consistent is that other countries have kept this daily cases per million down. The surrounding community spread has been maintained very, very much in the low numbers. And for many of them, it's because, guess what? They have really good suppression level testing and contact tracing and isolation still. Some of the other considerations that we're looking at besides these hard number metrics are things like the availability of PPE for staff and students, the availability of new treatments and vaccines, which is, there's some really exciting stuff going on there. Our current local outbreaks involving young people, and again, that's our local context, and any new research or guidance that may come in from the state or federal sources. So let's summarize our considerations. We really want to get to low risk status on the My Safe Start map. And so we would be looking at those 3 metrics carefully to see when our region is in that low risk. And additionally, for us, we want to keep looking at those local outbreaks, keep looking at the research, keep looking at other information that comes to light. And just to remind you, in case the data was too overwhelming from the last 2 slides, the slide before that showed us we are a medium high risk. We're in that orange category for the My Safe Start map. Okay, we're on the home stretch. So let's talk about that glorious day when we can get some of our students, we can think about getting some of our students back into school. So we know, and this is somewhat based on other countries, that it will be very difficult for us to get back and stay open unless we have really solid public health protocols. So what's it going to look like? So really, we're going to need for students and staff to all be together in this so that we can keep everyone safe. We are very concerned. We don't want to have people getting severely ill because they've returned to school. So it's the pre-screening. Again, now you're well-versed on the issues with that, but we still can do it. Case notification, isolation and quarantine, following the health department's protocols, and then really being solid and vigilant with our personal protections. So in closing, I don't want to be like bad news baccalaureate. There are hopeful signs of treatment and for treatments and vaccine coverage, and so that we will come out of this, it will get better. We also know that U of M students have started trickling back to campus. They're coming, and hopefully they're coming without things in their droplets. We must remain vigilant in our prevention efforts. I know it gets so tiring. I'm tired of it. Everyone's tired of it, but we have to remain vigilant and keep wearing masks, keep staying away from people. And so that will help us in AAPS keep our commitments. We will always err on the side of caution to protect students and staff. We will continue to pay attention to new research and guidance. We will continue to partner with Washtenaw County Health Department and other health authorities. Our number one goal is to keep people safe through this pandemic and come out the other side even stronger if we can. So with that, I will say thank you. And I just wanted to share something I pulled from the Johns Hopkins Bloomberg School of Public Health today that just adds a moment of levity of if animals had to wear masks, they would have to wear a lot of masks because they're unfortunately not like us and their noses are very far from their mouths. I'm happy to take any questions that you might have.
Thank you, Ms. Bad News Baccalaureate. I won't. That won't stick. I promise.
Please don't let it.
Thanks a lot, Trustee Lightfoot.
Well, it just may stick. It prompted me to raise my hand. I thought it was hilarious. Thank you so much. It was great. It was a great break from some of the information, which is great for us wonks and could be a little more difficult for others. So thank you. I just wanted to say thank you for the information. Thank you for sharing it with us. For some of us, it's not the first time saying it. So thank you for the consistent updates. And thank you for demonstrating an enjoyment for the work you do. It's so important for the public to see our team. We really have good people in the right seats on the bus. And they're passionate about their seat. And that helps not only offset the work of the superintendent and the board, but it helps allay concerns for the parents and the public that we have the right people that care and go above and beyond. You clearly are doing some things that are above and beyond as far as your commitment to tracking down that research and immersing yourself in it. And again, finding fun in articulating and narrating it for us and helping the parents get prepared for what's to come ahead. For you to talk about universal masking, that helps allay a whole lot of questions. Let's just get ready and let's just get prepared to make sure that our young people have what they need, and it leaves less room for a whole lot of questions and a whole lot of sort of waivers and deviations, if you will. So I just appreciate you. Thank you so much for the work. And I probably will call you that for the rest of the COVID pandemic, but I'll do it privately. Thanks so much.
Thanks, Trustee Lightfoot. Trustee Nelson.
I have a comment and then two questions. The comment is a big thank you for the work and for the clarity. I learned a great deal from these presentations that helps me to understand what I'm reading in newspapers. And so thank you for these explanations. The first area of questioning I have is that testing and tracing and the lag in test results. We live in a community which must have more lab space than virtually any other community outside of that Boston biomed area. Is there, and I know the university must be thinking about testing and how quickly they can get results. Is there any discussion of a different way that a different place to send tests so that we could get the results faster. And I know we don't have the kind of money that the National Basketball Association does, but we do know that some people have figured out how to get tests quickly or test results, and that seems to be a very important link which is missing.
Yeah, that is such a good point, Glenn. The last time I asked my epidemiologist friend at Washtenaw County Health Department how many labs they're receiving test results from, they told me 60. They receive, and I'm sure it's higher now. So for Washtenaw County residents, they're receiving test results from over 60 different labs, and they're all over the country. So people can get a swab at St. Joe, and maybe they're running the test right there at St. Joe, you get it back really fast. If you do a drive-through retail drugstore type thing, they're sending to a national lab, and they're processing those tests in the order of priority of which states are having the outbreak. So I have heard of people who it took them like 14 days to get their test back. And then of course it's all moot. So I haven't heard of any talk about opening up new labs in Ann Arbor, but I do know that we are shifting to pooled testing, which takes a bunch of samples. You guys have heard of this? Takes a bunch of samples, runs them all at once, so it uses less of the materials needed for the actual test. If they're all negative, good, they're all negative. If any one of them is positive, they go back and individually test each one using all of the materials needed. And so that can be helpful. I don't know how many labs are doing that way, that are servicing our local residents. But I do know that the governor, you got me started on testing, Glenn. This is my problem. Like, it is, got me. So supposedly we're getting 500,000 new rapid tests through a consortium that Governor Whitmer entered into with other governors. Where those are going to be deployed, I don't know.
The second area of questioning is what to expect in the fall. I was listening to a county commissioners meeting this I forget when it was, but within the last week. And in discussing the outlook, the county administrator, Gregory Dill, said that in their plans, they are assuming a surge in the fall with the return of university students and college students, and with seasonal effects and possibly other things. Is that what you're hearing too, that people are either quite apprehensive about or even projecting a surge in the fall?
I have heard people, I don't know about projecting, but definitely fearing it, because, we are going to all move more indoors. We're going to be in these closed spaces. Some of the closed spaces are going to require masks. Well, actually, we have that as our executive order right now, but it's going to vary a bit. So there is more potential when we get indoors. And we have a large new group of people that we love coming to Ann Arbor, and what that will brew up is another question. So I think it could happen myself.
My own conclusion from that is to, if we get some very good data in the first half of September, to be a little apprehensive about doing a lot of celebration until we get the second half of September, maybe even early October. And if we're getting good data at that time, that then we can start thinking seriously about beginning that transition. But to me, the lesson is to be careful about moving on the basis of the first half of September data.
I absolutely agree with you. We have to let things play out for at least 4 weeks, in my opinion. But, just me.
And again, thank you very much for very useful material. We're really fortunate to have you in our district team.
Thank you, Trustee Kelly.
Thank you. I'll reiterate how much I appreciate the work that goes into doing this research, but also boiling it down so we can understand it. It's a big task. And in that vein, I'm going to ask a question that seems pretty elementary to folks who look at this all of the time, but something I just want to make sure is clear. On the slide where you were able to do the apples to apples, the per 1 million number, when it gives a number of Washtenaw County per 1 million, that's not because we have 1 million people here. It's because we're doing the apples to apples ratio. And so if we had 1 million people, that would be our number. We have about 368,000,
yeah.
375. So our real numbers are lower than what's on that chart. And I just needed to, felt like I needed to say that just so people weren't like, there's not 45 cases.
So I actually one day did the calculations for looking at 100,000, added 100,000. It's actually, it is less helpful sometimes to look at it per 100,000 because then we can't compare against others who are bigger. So that's why I didn't show the 100,000 because then I couldn't show that chart to you, for example.
Yeah, I mean, apples to apples, whether they're big Granny Smiths or little galas or whatever, it's fine. I appreciated that slide, and I just wanted to help, repeat why we did it by per million, and
yes.
why I appreciate your clarity on that. Yes, and then my other question is a little tongue in cheek, but I do think it's worth putting out there. When we look at slides about how indoor air quality can play a factor in this, I know that there are people who will think back to a very big bond ask that we made recently, and the voters approved it. Why isn't our air quality perfect yet? We just passed a big bond.
I'm happy to take that, or Ms. Bacalor.
You go ahead. I'm good.
We do have, thank you, Trustee, for that question. We do have 9 schools that are receiving new HVAC systems in process, and yet with an average age of 63 years, this is an ongoing process that will take, our latest estimation is about 4 years to complete. So that's where we are in that process. And I'm hoping that we'll learn some things from this pandemic. If there are things we need to adjust on the next set of schools, we can learn and innovate through this.
Sure.
One learning is outdoor air is better, right? If we can do that. Yeah.
Snow pants for everybody. Okay, I appreciate that. I appreciate the simple question with the long-term answer, and I hope our community understands that even if we wanted to put brand new HVAC systems in every single one of our buildings this week, the labor community can't support that kind of demand. So we're doing the best we can. We recognize and value the voters' contributions to the work on infrastructure. It's what we were really clear that we needed. I think the needs here just really reiterate how badly that was needed. And so I appreciate that the team is thinking about that and thinking about best practices for rolling that out. Thank you.
Thank you. That's a beautiful preview for September presentation that the bond committee is a little bit familiar with already, but Mr. Lazzano will be bringing all the things that we are doing or we are planning to do, such as touchless restrooms and ways to get in and out without touching surfaces, which is in a number of other things. So that bond money and other sinking fund monies are all going to be very useful during this time.
Yeah, absolutely. Thank you so much.
Thanks. Trustee Basket?
Sorry about that. Thank you so much for the presentation. As my colleagues have already read, you are such a valuable asset to us, and your work is definitely a jewel to us. We're very fortunate to have you. How soon will your presentation be available?
It's up right now on Board Docs, and I think Mr. Cluley can get it up. Mr. Cluley, I don't want to overpromise and underdeliver. Is it tomorrow?
Right.
Tomorrow?
The PowerPoints themselves, tomorrow's shouldn't be a problem. I don't know exactly about the video. That'll probably be later in the week or over the weekend.
That's fine. I appreciate the fact, again, that our information is very transparent and available to the community. And we're probably, helping other districts as well, because we know, again, not everybody is lucky to have you. I want to revisit the contact tracing, and of the cases that we know of, how are they doing? How are those folks doing?
They're doing very well. Yeah, everyone has recovered. It happens that 2 of the 4 were completely asymptomatic.
Wow.
I didn't include that in the slide. I mean, this is just 4 people, so I don't want to say 50%. I don't want to get into that. But yeah, that just happens to be the case. And no one had serious consequences, medical consequences.
That's very fortunate. And in the contract tracing, are you ever contacted regarding subsequent illnesses that may have happened from that initial person?
So let me make sure I understand your question. So if someone else were to become infected from that original case,
yes.
So I believe, yes, that I would know that information, but I'm not rock solid if that's the case. I think it is, and actually I'm getting a lot of this clarified tomorrow probably. The system of communication back and forth is, we're solidifying that between us and the health department. So just from these first 4 cases, I know because I've just talked to them.
Sure.
But I could see if we ended up in a situation, and knock on wood we won't, but that there were lots of cases, it might be hard for us to know that. That's why I'm kind of qualifying it a little bit.
No, I appreciate that. And that was part of my question, because again, like you said, as more and more people have cases, and my concern is, we talk about the adults traveling out of county, where our students, travel between districts. No one just has friends in one district or one area of town. So as other school districts may decide to beat us to the punch in terms of going back to their buildings, our students can still be affected, whether it's, at a social outing or whatever. So I was just kind of curious regarding, what to kind of expect, if you will. And so that's just a curiosity question, and something, I guess, to look forward to. Thank you so much.
Thanks. Trustee Lazarus?
Thank you, President Johnson. I know the hour's late, and I just wanted to make it very clear to our community that we are very lucky to have Ms. Bacalor, aka Fauci, on our staff here. And I just want them to understand that we are not making the decision to go back virtually uneducated. This information is very valuable. We don't play with kids and teachers' lives and our staff's lives and our community's lives. And it is this information, I hope everyone gets a chance to look at the presentation when it's up on our website and really take the time to understand that this is a difficult decision that we're making, because this isn't the way that we want to deliver education to students, but it is what we have to do to keep everyone safe. So thank you very much for geeking out on this information, because it's very valuable. Appreciate it.
Thanks. Trustee Nelson.
I just wanted to make a comment that would go back to Trustee Kelly's question about air quality. I recall from a previous presentation that due to the good public support for our infrastructure, we have a digital system that we can quickly adjust the flow of air in our buildings. And I am not well informed enough to know exactly how it works, but there's an algorithm that one factor that's easy to understand is if it's really cold outside, you don't bring in as much outside air as if it's a very comfortable temperature outside. So in the district, we have improvements that we need to make and will make on our equipment. But we can also say we are at the forefront in this digital control of our system so that we can literally on an hour-to-hour basis adjust the air circulation.
Yes.
So it is as good as it can get with the current equipment.
That is correct. Thank you, Trustee Nelson, for making that point. That's right.
Right. So, so I just have one last question. I know we showed, you mentioned masks, and you showed the picture of the cute little kids with the masks, and Trustee Lightfoot mentioned this a little bit. I just wanted to be clear. Can you just share your thinking about if school were to resume, where the data or the research is leading us in terms of masks and young kids?
For me, the data are very clear that as a source control measure and probably as PPE, masks need to be universally worn in our schools. And if there's some adjustment that needs to be made for a few students here and there, that's totally fine. But we have many, many challenges, and that is one of our most critical layers that can help protect students and staff. We have to think about our staff and all the kids, and they're breathing away, and we need to make sure that we can protect them as well.
Okay. Thank you very much.